Welcome. I'm Rick Dempsey, and I'm here today to talk about pulmonary rehabilitation with the Breathe Strong Rehab team here at Future Care. This is the second of a 4-series Facebook Live event that we are hosting with Future Care, talking about the 4 specialties that make up the Vital Strong Rehabilitation Program. The 4 programs are first, Heart Strong, which is cardiac rehab, Breathe Strong, which is pulmonary rehab, and that's what we're here to talk about today. And third is Walk Strong, orthopedic rehab, and then Camp Strong, our comprehensive amputee management program. And the goal of every Vital Strong rehab program is to get you home faster and stronger after an injury or surgery. Now let me introduce the Breathe Strong team, Lubna Nabolsi. She is a senior speech language pathologist, and Alexander Gritchen, pulmonary rehab manager for Breathe Strong at Cherrywood, here at Cherrywood.
How's everybody doing?
Alex, can you tell us a little bit about the 2 Breathe Strong programs that we have here?
Sure. So the Breathe Strong program started in 2010. We found that people that were coming in to physical therapy and occupational were having actually a difficult time participating in the therapy just because they're having some issues breathing, and so would I if I can't breathe very well. Right. So we incorporated respiratory therapy to help out with physical therapy, occupational, as well as dietary, speech, and of course with the pulmonologist that comes in, and basically that's how we started, and that's how we first conceptualized.
And now, Lubna, you're a speech language pathologist. Tell us a little bit about some of the ways you evaluate and treat one of my problems, which is swallowing and speech.
Actually, that's a really good question. And you said you have some swallowing problems.
I do have some swallowing issues.
Well,
I'm starting to get this reflux at my age now, and I can't swallow things as easily as I used to, and sometimes I'll be sleeping in bed or something, and I can feel it wanting to come back up, so I have to kind of sit up and force it back down. Otherwise, I can't go back to sleep.
Actually, that's a pretty common problem, and we're actually going to do a little test today and see what it looks like inside.
You want to do a little test? Are you going to do it on this dummy? Or this dummy?
You're not a dummy, but if you'd like, I could do the test on you, I could do it on the mannequin.
No, do it on me.
Okay. Believe it or not, swallowing affects 5 to 16 million people, in the United States, and that's not even counting the pediatric population. So, preventing, fixing, curing swallowing problems, that is as important, I think, as any other part of the medical field, and it definitely affects people's respiration and breathing.
Right.
So we usually work pretty close with respiratory therapy, with our pulmonologist. And at Future Care, we also have trach vent units. We have 3 trach vent units at Future Care Irvington, Future Care Homewood, Future Care Pineview, and we're opening a trach vent unit at Future Care Capital Region, our newest building that you were talking about. So it's wonderful that we can actually help those patients as well. But right now, how about we can work with you a little bit and see what we can do.
I've had this problem now that I'm getting a little bit older, and I like to find out about them.
Absolutely.
So it's something that's really going on in my life right now.
Absolutely.
So,
and this,
okay, go to work, girl.
So this is an endoscopy test. It's called a FEES.
Okay.
So it's an endoscopic swallow study. And it's wonderful because we can offer we offer the service at all 15 of our facilities, and either myself or a select few of our SLPs who are already trained do these tests. We do them bedside. You don't have to go to the hospital to get it done. You could be in your room. You could be in a comfortable area, just like you are now, and it's minimally invasive.
It sounds simple.
Yes.
And not really all that invasive. But,
we're going to get started.
Don't be surprised if I sneeze on you, though. You're going to be tickling my nose a little bit.
A little bit. So this is my endoscope.
I trust you. Yeah.
And I'm going to just cover it with a sterile sheath. And we already did a slight numbing with a jelly a little bit earlier. So basically this is the scope. It moves, it toggles, and it's pretty soft. The hardest part is going in is the nose because it's just a pretty tight tunnel. You'll be fine. All right, and then after I get in, you'll feel it, but it doesn't hurt.
I'm not going to be gagging or anything like that, right? Because you numbed it.
I numbed it, and very few people do gag, actually. If I stick around in one spot, it might make
You haven't had a gagger yet, have you?
No, I haven't had a gagger yet. You won't be my first. And then once we're in there, we color some water with some green food coloring. So
Yep.
take a swallow, and then we can.
You want me to take it now?
No, wait till I'm in
Okay,
there.
wait till you're in
so
there.
Just let me make sure my
All
lights
right.
are on, so we can see once we're down there. Gonna move over. You ready?
Okay, I'm ready.
All right.
Go ahead.
There we go. Start my record button. So we're gonna just go through the nose. Pretty.
All right.
That was the worst part.
Yeah, that's not bad at all.
All right, and you can talk, right?
I can feel it in there a little bit, yeah.
Yes, you
I want
can.
to swallow the whole tube.
Well, you can swallow because I'm holding on to the tube. It's not going to
Yeah.
go anywhere. So there we go. We get to take a look at your vocal folds. So let me hear you say E.
E.
Beautiful. All right.
Ah.
All right. And can you reach the water?
I can. I
There you
can't
go.
see it, but I can reach it. Okay.
All right. And
And you want me to take a little bit in my mouth?
yep, please do.
Okay. I'm going to hold it till you say swallow.
Okay. So you 1, 2, 3, and go ahead and swallow. Beautiful. And you have a normal swallow.
I do.
You do.
Okay.
So I think some of the issues that you talked about were
Yeah, I've
reflux.
got that going for me now.
Yeah,
I got
and
a
then
normal swallow.
your sinuses looked a little bit large, so you might have some postnasal drip there.
Yeah.
So basically, with a patient who does have a swallowing problem, we would test several different consistencies of liquids and solids
Right.
to see which foods they can have and which foods they can't have.
Well, what else did you see in there? Is that
Well,
it?
I looked at your cords, I looked at your upper esophageal sphincter,
Right.
looked at the anatomy and the physiology, and everything looks normal.
Yeah.
So if a patient had a stroke, they might have some muscle weakness.
Right.
If they have issues with respiration, that whole entire process of the swallow kind of goes out of sync. They
Right.
might start breathing during the swallow.
Right.
And if that happens, they can inhale the food or they can inhale the liquid. And then that can cause to pneumonias and more breathing problems. So because the aerodigestive tract is so close, they're like row houses. They're literally just separated with a very small area of muscle. It's called the upper esophageal sphincter. And only one of those, either the trachea or the esophagus, could stay open at one at a time. You can either breathe or swallow. You can't breathe and swallow at the same time.
Okay.
Every time you swallow, you hold your breath. So that's called the apneic phase of the swallow. And sometimes for patients with respiratory issues, even though it's a few seconds or less than a few seconds, it can really put them into an exacerbation. So that's why working together is really important. One, we want to make sure the food and the liquid are going down the right way. We want to make sure they're not coming right back up. So we work really closely with our doctors, pulmonologists, and our attending. So if they need medication for reflux, then we would suggest that to them. Sometimes we would recommend like nebulizer treatments to help them while they're eating so that they're not short of breath. Oxygen breathing exercises, and I think you're going to talk about that a little bit more.
Yes, I will.
With trachs and vents, I have my dummy there, if we can talk about him a little bit. We have a speaking valve.
Right.
Let me go over there and show you. We have a speaking valve, and basically with trach patients, we can place a speaking valve on top of the trach, and basically they suddenly have a voice. Basically it closes off
Yeah, I've seen
this
that.
hole
It's
in here.
incredible. I don't know how people speak with
the
that thing.
stoma, the trachea. It closes this off so that the air, the exhaled air, can come up through the nose and mouth and vibrate the vocal cords, and they can achieve voice.
Yeah.
What's really nice about this valve, it also restores normal pressure for swallowing. So imagine a flat tire. So a car's not going to move very well with a
Right.
flat tire, but if you put air back in that tire, you're going to have a repressurized system. Everything's going to move a lot better. So sometimes with, this is what we do with a lot of our trach and vent patients, is we assess them for speaking valve and speaking valve tolerance. Like I said, it's not just for speaking, it's also for swallowing.
Right.
So it helps those guys a lot. And we use different kinds of valves, and there's a lot of training involved with working with these patients, but we're lucky enough to be one of the largest providers in Maryland for trachs and vents. We do a lot of work with them. We work very closely with the rest of the
Good.
pulmonary team.
Well, very well explained, Lubna. Thank you
you.
very much. Now, Alex, your turn. Tell us a little bit about the type of patients that need pulmonary rehab. And they typically are suffering from COPD, is that right?
Well, a large majority is actually suffering through COPD, but we also, we have patients with obstructive sleep apnea. COPD in general, a real good definition of what COPD is, because a lot of people ask me, well, what is COPD? And of course, I can always say it's chronic obstructive pulmonary disease. But in a nutshell, you breathe in a gallon, you're only going to get rid of half a gallon. The other half a gallon gets trapped in your lungs. It comes out just very, very slowly. But it's an umbrella term. So we have cystic fibrosis, emphysema, chronic bronchitis, asthma, and with COPD, like I said, that's a large majority of what we have. But we also take people that they're on a high flow tracheostomies, patients that have difficulty getting from point A to point B, to give them better, basically an overall good around, demonstration, as well as techniques and methods. And we always find therapy to be an art form. And what we do is we train somebody that has these breathing issues, whether it be COPD or not. And we actually, with techniques and the methods, we actually train them how to get from point A to point B without being so darn out of breath.
Right. Well, I know you have a lot of fun and engaging ways to help your patients breathe better.
Yes.
Explain how you do that.
Well, would you mind if I can demonstrate something?
Yeah, absolutely.
Oh,
Let's go.
fantastic. So right here, you have an incentive spirometer. Mm-hmm. Have you seen an incentive spirometer before? A lot of these incentive spirometers are given to people in hospitals and in rehab, but a lot of people aren't shown how to actually use this. And I always look at technique and methods to be, everything is an art form. I see a lot of people trying to train somebody how to use an incentive spirometer, but they don't really show you. So they say, try to use this. And you actually have one right there specifically for you.
Oh, really? Okay.
And if somebody just asked you, and we see this time and time and again, if somebody asked you, can you go ahead and breathe in through there, and what would you do?
What would I do?
Yeah, just by breathing in. This is a usual demonstration. Okay. So that's just on one volume. Now, watch technique. So what I like to do is tell somebody first to sit up straight. Posture is everything.
Right.
If you slouch, you're going to compromise your breathing because your diaphragm. Exactly.
You
right.
can't use the muscles.
So what I tell people is first, take a deep breath in. You don't have to, but I like to start it off. Every single time you take a breath, 30% of the oxygen in that breath goes to your brain. 20% goes to your heart. That's 50% of every breath you've ever taken.
Right.
If they don't get that, you're not going to function very well. You'll have a hard time sleeping, a hard time getting from point A to point B, memory, all sorts of jazz. But what I tell people first, because this is a measuring tool, this is not an exerciser. So the rule of thumb is keep your back straight.
Right.
All right. I'm going to take a deep breath in. Then I'm going to exhale, getting rid of all the air out of my lungs, out, because I want to correctly measure. Because right now I have some residual volume. I want to get rid of that. So exhale for 4 seconds or more. So watch what I do. I'm going to exhale for 4 seconds or more. Getting rid of it. No air left in my lungs.
Okay.
I'm going to make sure that this right here is what we call a flow meter, and this is a piston. I'm going to make sure that is in the box and keep it in the box as long as you possibly can. So I'm going to exhale.
Wow.
Pull my back up.
Yeah.
And I'm going to exhale again. I'm going to give 3 tries, and then I'm going to actually average them out by adding all the numbers up and divide it by 3 to give me my average. I'm going to note my volume. If I am doing less than 2,000, I'm actually breathing not as well as a human being. So basically, I find a lot of people coming in, they max out around 500 milliliters.
Shallow.
Yeah, very, very shallow. And they can't breathe in any larger. 500 is good enough for a squirrel, and that's nuts. I always find that when they exhale, all the way, and we really check, but if they're only at a 500 to 1,000, their maximum volume, I need to work with muscle training. and that's respiratory muscle training. And that's something we do with, we can use pursed lip breathing, diaphragmatic breathing. We can actually use coffee straws. And I'm a guy that knows a lot about different types of techniques, but a lot of, anytime I see somebody lower in volume, I know where the problem's at, especially if they're wearing supplemental oxygen. If they're wearing supplemental oxygen, their lungs, instead of opening up all the way like a normal lung would, they only open up partial. I got to retrain those muscles. The muscles responsible are all those intercostal muscles and the diaphragm. So when I breathe shallow, I'm using maybe 1 or 2 intercostal muscles. I'm not working all 10 out, you know? And I'm going to retrain my lung fields, or the person's lung fields, to open up all the way. Because a lot of people think that they only have 2 lungs. Well, you have 2 lung lobes. You have many segments. You know, there's actually 12. And these different segments, they all contribute to oxygen gas exchange and elimination of CO2. So if I find somebody not breathing deep enough and they can't breathe in any deeper, I retrain their lungs doing full repetition with respiratory muscles to gain that.
So what you're saying really, if you don't use those muscles to take a big breath, then it really affects the amount of oxygen your brain gets, most of it, and your heart.
Absolutely.
At the same time. So
absolutely.
It can become an issue.
Oh, absolutely. And if they can't breathe in deep, they have to, instead of 1 good breath, and let's say that 1 good breath is about a gallon of air, and they're breathing only very shallow, and they try to take a deep breath, but they can't because their lungs are too stiff. I lack the muscle. They have to breathe 4, 5, 6, 7, 8 times to equal 1 good breath. Meaning if you ever notice somebody with low, shallow breathing, they're always breathing fast. So you ever notice yourself ever breathing fast, just
short and fast?
Yeah, just short and fast. Because I've always been breathing like this. There's an issue. Their body's trying to compensate by having them breathe faster and faster, and then it becomes a complication.
So you want me to do this thing?
Actually, another fun way is through harmonica training.
Really?
Yeah. So I have a harmonica here, if you wouldn't mind.
No, let's do it.
Oh, that's fantastic.
Eat your heart out, Stevie Wonder.
Believe it or not, we have harmonica training. And harmonica therapy is a form of breathing, but for fun. Having fun with it without it being so, it's therapeutic, don't get me wrong, but it's a fun way to breathe. So I'm going to go over just a small, I have my little handy harmonica. Very simple. People that come into the therapy group, I tell them, give me 15 minutes. And we're not going to do it for 15 minutes, but I tell them, give me 15 minutes, and I promise you, you'll be playing jazz at the very end. And they're all they're like, yeah, right, that's not going to happen. And they're always skeptical, but at the end, they're surprised. They're actually playing jazz. It's just in a fun way, and I don't make it so difficult, I make it very easy to understand. So the very first thing is the numbers on a harmonica, 10 to 1. All I want you to do, we're going to do a quick, easy tune. You're going to play in the middle of the harmonica. Okay? So let's pretend right now that behind me is a harmonica. Okay? I'm going to stand in the middle of the harmonica. When I do this, I'm going to breathe out. When I do this, I'm going to be breathing in. Correct? So we're going to do what we call the choo-choo train. It sounds very petty, but it's a prerequisite to higher and more advanced levels.
Right.
So it's just getting a good breathing pattern down. So what I'm going to do is this. Very simple. And it's the train. So we're gonna kind of replicate a train. So go ahead and breathe in, out. Good. Now the train has a whistle. All right. So the big long, the long whistle when we do this and they honk their horn there, that big whistle.
The choo-choo.
Yeah, the toot. Well, the toot. The toot is actually played just a little higher. Very simple. You can play on the far right-hand side. Yeah. Okay. So let's do a quick tune. Just the same thing. Okay. So now we got a good breathing pattern down just a little bit. We're going to start, and I'm going to tell you when to begin. And as I do this, you're going to be breathing in and out. And then when I say, toot the horn, you're just going to move up to the right and breathe in through that harmonica. You don't have to hit single notes. Right. Just point. Okay, as a toot. Okay, so we're at a train, all right? We're in a train, and we're going to start it up. So I'm not sure if it has a steering wheel or not, but anyways, I start the engine up, and it's going to chug, 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 okay? That's what you're going to be playing. So here we go. All right, so we're going to be breathing in, slow start. All right, we're starting to move faster now. Now we're going. There's some people in the way. Toot the horn. Good job. We just saved them.
Hey.
Absolutely. And that's just a really
I could get a recording contract.
That's just a really quick way of a simple demonstration, of how we practice harmonica therapy, harmonica training, and all that jazz.
This is awesome. This could be a lot of fun.
Oh, absolutely. A lot of people really do enjoy it.
And I bet people really want to play the harmonica after doing all this all the time.
You'd be amazed, actually. We have a whole, called the Harmaniacs, actually.
Yeah, that's awesome. So, okay, so now you've got the pulmonary rehab program and then physical therapy working together.
Yes.
And this is how it all. So that's pretty interesting. So anyway, I hope you've enjoyed hearing about Breathe Strong program. You got to join us again on September 26th right here on Facebook when we will be discussing orthopedic rehabilitation, our Walk Strong program. We will be at Future Care's newest facility in Landover, Future Care Capital Region, and show you a brand new and beautiful state-of-the-art rehab gym. That's September, again, 26th, discussing the Walk Strong program. Hope to see you then.